Dr. Allam Sayyid Allam. Dr. Allam is one of the very active existing member in our interventional radiology unit at Ain Shams University. He will talk about post-liver transplant catastrophic event.
Good afternoon. Thank you, my dear colleague, my dear professor. My talk today is about post-liver transplantation catastrophic event. As we know that liver transplantation, it is a surgery when we replace a healthy liver by a diseased liver by a healthy one. Either it is a total liver, like in cadaveric liver transplantation, or a part of it, as in living donor liver transplantation. In liver transplantation, we have 4 anastomosis. We have the peri-anastomosis, the hepatic artery, hepatic vein, and portal vein anastomosis. These anastomosis are liable for complication, and that's why the early diagnosis and good management of these events can prevent a catastrophic event like in our case. This is a case of 56 years old female patient who has, after liver transplantation, a myeloma. A bacteria was inserted, and unfortunately the myeloma didn't resolve by itself. So ARCB was done, with stenting was done. After a couple of days after the ARCB, the patient had a shock. It has a hypovolemic shock and hemoglobin drop. We don't know why that happened. So we did a Doppler ultrasound that shows there is no hepatic artery flow inside the liver. And the decision was either we go to the surgery or we have to do an emergency diagnostic angiography with possible of embolization. So the decision was made for a diagnostic angiography with embolization. When we do a hepatic arterial angiography, we see this event. We have an extravasation of blood from the hepatic artery. So the decision was we have to stop this bleeding, this extravasation. So by hepatic angiography, using stents, we put a coronary eluting covered stent to stop this bleeding. Unfortunately, the bleeding doesn't stop either, so we use microcoils to stop this bleeding. Like in our case, after putting the stent as a coil, the bleeding stopped, the hemodynamic of the patient improved, and so the patient was went to the surgery for removal of the hematoma deformed and to show if there is still bleeding are there. The tools used in this case, we have the catheter guiding 6 French. We use the PT2 guiding wire. We use a dilatation catheter. We use a coronary eluting tract stent, and we use microcoils. After surgery, the hematoma formed from the bleeding was removed, and the patient was admitted for the ICU. Complication of hepatic artery includes the hepatic artery thrombosis, stricture, and pseudoaneurysm formation. Hepatic artery thrombosis is represent about 50% of the hepatic artery complications that can occur after liver transplantation. The incidence is about 3.5%. It can occur in early or late after liver transplantation. The actual predisposing factors are known, but family factors are lead to this complication, like technical errors or the long segment of the hepatic artery itself. So early diagnosis is important. Hepatic artery thrombosis can be diagnosed clinically by the presence of increased lactic acid and the clinical picture of elevating liver function. Doppler ultrasound can help to detect that there is no blood flow or diminished flow on the hepatic artery, and so diagnostic angiography can be done with stenting, and balloon dilatation can help to remove this thrombosis of the hepatic artery. Hepatic artery stenosis is represent 2 to 13% of the of the hepatic artery complication, and about 65% can lead to thrombosis. The median time for diagnosis of it is about 100 days after liver transplantation. Most of the hepatic artery stenosis cannot be diagnosed earlier because it is asymptomatic. However, Doppler ultrasound and CT angiography is the main method for diagnosis of the hepatic artery stenosis. Significant hepatic artery stenosis can be diagnosed when we have more than 50% of diameter reduction and with decrease the resistive index beyond 0.5%. Also, hepatic artery stenosis can be treated by interventional etiology by balloon dilatation and putting a stent. Hepatic artery stenosis can be presented by anatomical, like in this case, with no damage in the distal blood flow of the hepatic artery. These cases, but we have a more than 50% of diameter reduction, so dilatation can be with stent formation, with stent insertion, can remove this condition. Hepatic artery pseudoaneurysm. It is very rare to occur, but it can present about 30% of the hepatic artery complication we have. Mostly it can occur in the extrahepatic portion of the hepatic artery. It can be asymptomatic, but in late case can be to a catastrophic event like the case I presented earlier. The risk factor can be the biliary leak, can be peritoneal infections, or other factors can affect of it. The treatment of the hepatic artery stenosis can be by surgery or can be by interventional surgery by we put a bypass stent, or we can use a coil for treatment of this condition. Early diagnosis of the hepatic artery complication can preserve the graft and can preserve the patient life. Duplex ultrasound and confirmed contrast study CT can help of diagnosis. The question is when we do interventional etiology, it is surgery or interventional etiology first. This is the question. A variable tool can be used to save the times of the patient. Thank you.